All right, we are recording. Just to recap, this is Dr. Hawley here. Call me Brian. I'm turning off some options here, getting some last minute preps. All right, now you guys should be able to see my screen here. We have some housekeeping here. Questions. Well, first of all, a lot of you guys, this is a huge turnout, guys. Thank you for coming on here with this. I really appreciate this. Normally I don't get this big of a response, but wow, I guess this is a pretty popular one. I guess scars and fascia, everyone has them, right? So a lot of you, I don't recognize the emails. So and I've gotten some things saying that you've never attended a webinar before. Some of you've never attended my webinars. I got to be honest with you. A lot of these I fly from the cuff. I try to keep them light, and sometimes a little humorous. I think that's the way we humans learn. So that's how I was all through school, and it's kind of how I live my life. Okay, so hopefully you guys will enjoy. If you do, shoot me an email. Say, hey, it sucked, or you really liked it. Okay, either way. My background: who am I? Pushing middle age now. Been in healthcare since the 80s. Went to medical school, then went to chiropractic school. Owned several clinics, toured the country teaching, speaking. What else can I say about me? Married for 30 years. My wife is a massage therapist. We also taught together at a local massage school. Um, and here I am. I'm talking to you guys. So now we had recently sold. Oh, big move. We recently sold our practice and my wife's studio. She had a multidiscipline studio. She had several massage therapists, naturopath, and acupuncturist in there. And she did basically medical massage is what she really did. Um, because we had our clinic. I had my team of doctors, and we just referred them over to her and the staff. So that was their specialty for years. So we recently sold all that. We just sold it and we moved to the beach. And now I am doing speaking and webinars and online consulting, basically setting up Facebook, helping therapists like you guys and other healthcare professionals get the word out for marketing via Facebook. So I'm doing that now. So, and I like it. So, what we're going to do here, so that's kind of who I am. Notes. This is being recording. Let me just make sure. Yes, this is being recorded. So give me a little bit after this. Give me a couple hours to get it converted and uploaded, and then I'll get a copy of this along with the notes. I'll convert all these slides to a nice PDF format, and I'll send it out to everybody along with a mini exam. Now, what's the mini exam? I've gotten a few emails asking about this exam. Guys, here's my off the record. Well, I guess I'm being recorded, but it's still, I'll say off the record response. We are all professionals. We've done enough exams in our lifetimes. So I'm not going to make my exams tricky or hard. It's just an attendance exam, basically, multiple choice to make sure that you were here either live or watching the video presentation. Okay. So that's all that is. So I'll email that out. You can email the answers. Just send an email with just the answers only. Number one is B, number two is C, whatever it is, back to me, and I'll have my assistant. She'll grade them, and she'll send a certificate. Now the certificates, I'll try to get out as they come in, or actually my assistant does. I may even field a couple if they let me on the computer at night. I'll go ahead and make sure that those get out. So when you send your test back in, make sure you put your name along with any credentials, how you want them to appear on the certificate. And some of you guys out there, you're like overachievers, man. You got like the whole alphabet after your name, so it's pretty impressive. So just kind of, if you have the alphabet, the 26 letters, give me like 5 or 6 because the certificates aren't that big. Okay. So if you have questions, let's hold the questions off until the end. And to be honest with you, the best way for me I found to answer the questions is to just shoot me an email. I'm here for the next hour and a half or so after the webinar, preparing and uploading and getting the videos ready. So I'm going to be answering questions and everything else. And instead of me giving an off-the-cuff answer during a webinar, you get more precise and accurate answers if you just email me. And it doesn't have to be right after. It could be next week. We're all on the same team. I get emails daily with questions, and sometimes I have my wife answer them if I don't know the answer from webinars I did a year ago. So I don't mind at all. We're all on the same team. And for my gang that's hung with me from day one, you guys are awesome. It's good to see you guys in the new year, and we're gonna rock and roll like we always do. So we're probably gonna be putting more stuff on. My goal this year is to do some live seminars where I'm up on the stage and I get to actually shake the babies and kiss the hands. I get to actually meet the people, right? I think that would be cool. So I might even tour a couple schools and classrooms and maybe do some guest appearances at some of the seminars around the country. I would love to do that. So if you see me there, come on up and say, hey, I'm part of your organization. Hey, I took a webinar from you, and let me know who you are. So, all right, without further ado, guys, let's go ahead and begin. Let me see if I can maximize this. Let me see here. Now, I don't know if let me see here. We're having a little snafu with the slides. They're not cooperating. All right. All right, we're going to run through this like this. All right, so here we are. Now, you guys should see, just to make sure, because we're having some slides. I have dual monitors up here, so we have some multiple things going on at the same time on two different monitors. So right now, you guys should be seeing pain heals, chicks dig scars, and a good massage also helps. You guys should be seeing that. Okay? Go ahead and just give me a hands high if you are to make sure we're on the right monitor. I think we have everything set and we'll go. Awesome. All right. So that was off of Keanu Reeves. I was putting this webinar together and that movie came on. It was The Replacements, and he was talking about scars, and I thought that was kind of cool. So I thought I would just go ahead and throw that in there. So when I started learning about scar tissues, I've had tons of microbiology, and one of the questions about this was, are we going to look through microscopes at scar tissue and learn about cells and fibroblasts and chondroblast? No, we're not, because whenever I was in these labs and going through all this class, staring at the microscope for hours really didn't mean nothing to me about how to apply it in real life. It's like looking at a Picasso from a half inch away. You really don't know what the heck you're looking at. So, obviously, yeah, I can tell you the stratum corneum, the dermis, the subdermis, the chondroblast, the fibroblast. There's a lot of stuff here that we can see. So what I wanted to do was try to make it more real world for you guys. Okay. So let me see here. I'm getting a question. Let's see if we can make this big. All right, so I'm going to hit on slideshow, but I think it might default to the other screen, which I'm worried about. Hold on. Let me try something here. How about that? I just made it big. Can you guys see the big now? Yes. All right. Thanks, Susan. All right. Let's go ahead. Now we're going to rock on here. Now, so what is scar tissue? Okay. Scar tissue, obviously we know this forms after injury basically it's a proliferation of normal collagen cells. If you cut yourself, you have surgery or tear a tissue, you're going to get a scar. Okay. Now, it's normal. It's a normal healing process. Now, scar tissue is composed of the same protein, i.e. collagen, as a tissue that replaces it, but the fiber composition of this new protein is different. It's a little different, okay? Instead of a random basket weave type formation, think of the Chinese finger puzzle, right? Instead of a random basket weave formation of the collagen around normal tissue, these form a pronounced alignment in a single direction, okay? And then later, we're going to get involved a little bit deeper. And I'm going to say later, you can start to get where it goes all over the place, kind of like an asterisk. And I'll explain that in a little bit more detail later. But one of the cool things, a trivia question, if you're, I guess if you're at a bar or something, sweat glands and hair follicles do not reform in scar tissue, okay? So they don't come back in there. Okay. So imagine burn victims, ones with severe scarring. Okay. Now there's some categories of scars. Okay. And this whole webinar is not going to be about scars because, I was talking to my wife the other day. I said, what'd you tell me about what you went over with in school with scars? And she said, well, we kind of took about an hour. That's about it. So obviously there's not a whole lot, but we're going to cover some of the stuff. So I wanted to start off with the categories. You have the keloid, the contracture, the hypertrophic, the acne, and the atrophic. Okay, so what are those? What do they look like? What do we do? Well, here we are. The keloid scars are basically, it's an overzealous healing process. You want to, it's like healing on steroids here. Basically, they extend beyond the site of the original injury. They go beyond the borders. Okay, now over time, it may hamper some movement, especially if it crosses a joint plane like an elbow or a knee or across a shoulder girdle. Okay, some of the smaller ones can be treated with cryotherapy, ice, or liquid nitrogen in severe cases. Okay, basically, you can also help prevent keloid formation or the spreading of these in the early stages after they've closed up with gel pads and silicone when you're injured. Keloids are most common with people with dark skin. And you can kind of see some of these, how it goes beyond kind of the border, it spreads around. This was a scab line around here, but underneath the white is actually a form of collagen, just subdermal. And we'll get into that a little bit. And you can kind of see how it's spreading beyond the border. Those are keloids. Contracture scars basically is from burns, okay, or severe chemical reaction burns, okay, or fire burns. Basically, they tighten the skin. It's like getting a severe facelift. It's really, really taut. Okay. Now, if you go beyond this, this goes into the dermis and subdermis. You can also start affecting the nerve endings. You can also start affecting the muscles involved, because remember, the muscles attach to the fascia, which attaches to the collagen, which attaches to the fibers and the fascia. It's all connected. Okay. So that's a contracture scar. Now, the hypertrophic scars, a lot of times these are confused with keloid scars. So I found a picture. Basically, the hypertrophic is kind of contained. Okay, it's kind of contained within the border, whereas the keloid, it kind of branches out beyond the border. Okay, and you can kind of see some of the ones up in the sides here, how they're kind of nice and contained. Okay, they don't go beyond the boundary of the injury. Okay, now they also can bubble up or bump up. Okay, so those there are hypertrophic scars. That's the difference with them and the keloids. Okay, now acne scars. Man, a lot of people suffer. They have a hard time with this. If you've had severe acne, you've probably got scars to prove it. Again, there's many types of acne scars and they classify them on certain degrees of scarring, certain types of scars, like a pitchfork, like a wedge scar, like a bowl or a square scar. I mean, they really get in deep on defining acne scars. But basically, I know everyone on here has seen pictures of these, and same thing. Some of the clients you've probably worked on their back. They have the post acne scars. Okay. Now, sometimes can you get rid of some of these through chemical peels and dermablations? Sometimes with the laser therapy. The purpose of My purpose of this webinar is not to go into the healing of the acne or healing of the scars so much, because I teach what we did and what we do in our clinics and in my wife's studio and what we've seen over the years. I'm sharing with you. So we didn't go in and advertise healing scars or healing of acne scars. So I'm sharing with you some of the things. Now I'll mention some of the tips along the way. So you women, if you're looking to get rid of the wrinkles from this webinar, I'm not going to provide a whole lot of that, okay? Atrophic scarring, which is also sunken scarring, basically it's an overexpression of collagen blocking the regeneration. It kind of holds all the regeneration out. Basically, it's a sunken type scar. It's an indentation because the collagen do not overextend the tissues. The scar the collagen will not go beyond the scar borders. It stays right there, so it kind of sinks in. Basically, stretch marks, striae are regarded as scars by some. Okay, some of the dermatologists actually regard this as scarring. Okay, now injuries. I went over this in one of my injury webinars, but basically, if a muscle and tendon were cut or repaired, scar tissue will develop within the muscle itself. Obviously, we know that it does. Scars just don't happen in the skin, okay, or on the skin. Excuse me. I have seen a lot of this with my decompression therapy practice. People would come in post surgery. They don't have hardware, but to get to the disc or to do a osteotomy, open up the foramen, the IVFs, they have to do an osteotomy. To get to those, sometimes they have to cut some of the muscle. When they put them, when they sew them back together, scar tissue will form. Now, a lot of times we can't predict where scar tissue will go, and it's so deep down in the multifidi. If it was just on the superficial erectors, we could probably deal with it with stroking, with massage. But some of the deeper ones, it's hard to predict. And that scar tissue will actually form a web. The collagen matrix the fibroblasts will just go nuts, and they will put all sorts of scar tissue around the nerve endings, the DRGs, into the IVF foramens, and the people have to go back in for a second surgery just to remove some of the deep embedded scar tissue. Okay, so a lot of times people will come in and say, I have a muscle tear. Do you think you could help with some of the scar tissue? You think you can help with it? Well, there's different grades of muscle tear. Nice to kind of know. Grade 1, grade 2, grade 3. Basically what I have found whenever I'm doing an exam is a grade 1. If I passive motion, if the person, how can I put this for an example? I didn't get a picture. If a person is sitting on my table with their legs hanging off, they're sitting down, and I ask them to extend the leg, and their quad muscle hurts. Then if I go ahead and I extend the leg, they are totally passive, and it doesn't hurt, then they probably got like a grade 1. If I go ahead and passively move it myself, and it still hurts, number one, you got to rule out a joint. But if the joint is ruled out, then you probably got a grade 2 or grade 3 because you're still involving the motion of the muscle. And when you get a grade 2 or grade 3, just the muscle motion itself will cause some deep pain. Okay, so keep that in mind. And you apply that to all joints, all muscles. Now, bony scar tissue is often called a callus. Don't confuse that with the hard working man's callus on his hands, right? Stuff that we don't like to feel when our massage therapist is rubbing our back. We don't want them to have calluses. So I have had a couple like that, and it's like, oh, that don't feel good. But basically, it's called a callus. It will form on the bone after a fracture. The periosteum, the outer layer of the bone, will actually start, the osteoblasts, and will start really forming this protective barrier around it. Basically, then scar tissue will start forming around that, okay? So we got to make this relevant to us, right? So how is this relevant to the person laying on my table? Okay, why is that relevant? Well, many times I've been in the clinic, and I always had the therapist in my wife's clinic coming over, and we'll pull up the patient's x-rays because they can feel something right on the bone that doesn't feel like bone. They don't know if it's a calcified lipoma, a lymph, scar tissue. They don't know if it's a bone callus or what. So more often than not, we would look on the x-ray, and we would see it's more of a bone callus with a severe scar tissue formation around it. So basically, if you have like a person laying on your table and they've had a fall, they slipped and fell on ice, and they had like a clay shoveler's fracture, they went ahead and they have a chip in the spinous process, well, that will form like a callus around it once it heals. And if it's immobile, and now obviously that's going to be, if you put your thumb right on that until it's healed, it's going to be really painful, like a push button. Push button response is what it's called. But then it can start forming a callus around it, a scar tissue bundle around it to help protect it even more. So when it gets to that stage, when it starts forming some of the scar tissue around it, then you want to really start working that scar tissue, try to get it loosened up. Otherwise, it's going to create immobility problems and start causing disc pathology eventually. Same thing is when we get the hump on the back of the neck. I know someone out in the audience is thinking of that. Looking at the computer for so long, leaning over, text neck syndrome, all those things, you start getting the pronounced C7, T1, T2 region right at the base of the neck, and it's like, oi, you know. Now you're not really forming a bone, a callus. Severe cases through osteophytes, through syndesmophytes, through osteophyte formation, then you can start forming a little bit of a callus, and then you really get a big scar tissue bundle around that. Then that makes it more immobile as time goes on. Now, you can also have a transverse process, or even a floating rib that will cause some things. So how do we tell? Quick down and dirty. How did we tell if it was a callus or a calcified lymph or something? Well, basically the callus is not going to move. Okay, if you have like a lipoma or a calcified lymph gland, if it's in the region where the lymph gland should be, of course, then you get that one person that it falls outside the norm, but they're going to be more movable, more mobile. Movable, that's a new word we just invented. It's going to be more mobile. You can move it around a little bit. Now, a lot of people will ask me, I'll have patients ask me, well, what do we do on those? Well, if it is like a lipoma or something like that, if it's not fibroid in nature, if it's still a lot of fluid in there, then the doctor can go in and get a syringe and aspirate it. They'll do just a local injection and numb it and aspirate it out. Then normally about a couple weeks later, we can get in and start really digging around and doing stuff after it heals. But that is some of the relevance of a callus, what it can mean to us. So when we have a client on there, we feel something that's pretty hard and lumpy and bumpy, it could be a callus. You could always ask them in your intake forms, say, did you ever have any broken bones? That's one of the things we started asking later on in the practice, after a couple of years of being in practice, is, do you ever have any accidents, any broken bones? If so, where? And how long ago? I mean, obviously, you don't want to just have one just get out of a cast and start doing some major pressure on them. Okay? So just a little inside tip there. So I've mentioned collagen. So what is collagen? Now, some of the schools, they have a lot of biology, a lot of micro in them. Some have very little, like the one my wife went to. So basically, collagen is a substance that's present basically in all our body parts, is what keeps us together. Collagen, muscles, tendons, ligaments. There's also in skin and bones. Basically, on a cellular level, it's very strong due to the alignment of collagen cells. Basically, it can resist tactile forces of stretching, pulling without tearing or breaking. Okay, these here are like myofibrils. This here is in the subdermis. This here is down by the bony matrix over here. Okay, fibroblasts are the cells that start spitting the collagen matrix out. Now, how does the scar? What is some of the things that happen in the process? Instead of putting all the pictures, it would have been like 5 slides. I figured I'd just verbally vomit this on a slide and kind of go over it real quick. Basically, we get a cut. So we got to patch. We got to stop the damage, okay? So we first create like a clot, right? The histamines, the kinins and all those things, I'm not going to get into all that. But basically we form a clot, okay? That will provide a provisional matrix. Just stop the leak for right now. Now, in the process, the first layer is a provisional matrix. It's not a scar. Basically, think of a cap on the clot, okay? Over time, that's whenever you first cut yourself and it stops bleeding. Then you go do something, you kind of stretch a little bit for some reason, or you go pick up something, and the sucker reopens up and you're bleeding all over the place again. You had just a cap on the clot. You didn't have a scar yet, okay? So you're in the very, very first stage. Over time, the wounded body tissue will express collagen inside this matrix, okay, inside the clot matrix. Now, this will start putting out collagen fibers all over the place inside, making it a dense little matrix inside this clot. Okay, now this is a densely packed, okay? And then it starts, when you start seeing where it's so dense, it will actually be non-elastic. It's not movable. It's whitish, okay? Kind of like a pasty white, okay? It's a scar wall, blocks off all cell communication and regeneration. As a result, new tissue generated will have a different texture and quality than the surrounding unaffected or non-wounded or unwounded tissue. Now, the scarring, now we just have the clot that has kind of really got dense white with collagen, okay? Now, the scarring is created by fibroblast proliferation that begins reaction to the clot. They mend the damage by slowly forming a collagen scar, okay? Basically, it's circular, and cyclically, the fibroblast lays down a thick, whitish collagen inside the matrix, resulting in the abundant production of packed collagen. Basically, it's just spitting it out like the silly string. If you think of the can of silly string, it's just spitting it out all over the place, covering it up. And that's where you get the uneven texture. It just builds upon each layer and upon each layer. Kind of, yeah, I was going to say, I thought I had a slide with a picture of it. Basically, here's our skin, our dermis, the epithelial tissue, and stratified. And, I remember those from years ago. Basically, here's our clot. First of all, we'll form that cap I talked about. Then we'll start forming internal stuff. We have all our kinins and everything else helping stimulate the blastic activity. And then we'll start walling it off. Then we start getting our collagen fibers forming here, and they'll start going the intramatrix all through here, okay? That is what I was talking about. Now, the good thing and the bad thing, it stops the hemorrhaging, and it starts plugging it up. The bad thing is it's not as pliable. So if it crosses a joint, then we got to really deal with it, okay? The other bad thing is sometimes nerves can be entrapped within or between the adhesions, causing pain and inflammation, some type of a neuritis, okay? So we got to be mindful of that because some of the scars are actually painful. Some of the people would ask me, well, my scar doesn't bother me on my left leg, but on my right leg, my scar is extremely sore when I touch it. Or it's really sensitive to hot or cold or light. Why is that? Well, that is the reason why, because sometimes the way it just the silly string is being laid out, it can entrap nerves in it, and some of those nerves are hypersensitive, okay? And sometimes it doesn't, just the way it's laid down. Now, I know some of the women are out there are asking, well, all right, this collagen, I've heard of that in my wrinkles. What do we do about that? Well, first of all, I'm not going to tell you what to do about that. That's not my area of expertise. That's my wife. But when we're younger, we have our outer layer and down through here. We have our collagen matrix all down here. They're really elastic and they're pliable, and the fibroblasts are putting out new stuff, right? Then as we get a little older, the wall starts to break down of the collagen here. They start getting older. They start degrading. The elastin disappears, and you can start putting like little pits in, okay? Then as we get more seasoned, we have a severe lack of collagen and elastin. Now, I can tell you, smoking, stress, UV rays, extended exposure of sunlight, number of things can cause this to start a lot earlier in life, okay? So now one of the things, so how do we treat it? What do we do if we have something like this? Now, here's this up close. If you're trying to treat some of this down here, keep in mind if you have a topical, the molecular weight of the topical thing has to be less than 0.5 kilodaltons. Okay, you can probably look up on the chemical formula of the thing on Google of the product you're trying to do, if it's a topical, because the stratum corneum will not let anything greater than 0.5 kilodaltons penetrate down in. Okay, so you're not going to do any good with some of the topicals if it's greater than a 0.5 kilodalton. The only way to get it, if it's bigger, to get down in here then is through oral. Okay, that would be by the blood vascular system through there. So keep that in mind if you're looking at products, if you're doing things. I see a lot of them out there wanting some of the heavy creams and all that. Well, they aren't getting down here. They're just doing the top layers. They aren't getting down with the collagen. So keep in mind on that. Don't be fooled in getting a lot of the products out there. Okay? But that's what happens with collagen as we get older. Seems like everything kind of stops as we get older, right? Geesh, or it slows down. Now, scars and tattoos. A lot of people, because tattoos are becoming more, well, it's kind of like the thing now almost. A lot of people have tattoos. So keep in mind, if you see a tattoo on a person, my wife started just kind of rubbing over the tattoo first, not digging right in deep, just kind of rubbing over, feeling for lumps and bumps and abrasions, because a lot of people are using them to cover up scars. Okay. So just keep in mind now, some of them are pretty cool. I mean, I got to be honest. If I had a big scar, I would probably do something like that. I would really consider that. That's just me personally. So unless it was like a cool scar, but just to keep that in mind as you're working with people that have tattoos, you can always ask them about some of the scars if they have scars. Tattoos nowadays are really covering up a lot of stuff. I also get asked, is scar tissue permanent? Well, you have to define permanent. If you're defining permanent to be within 6 months, well, then yeah, if you're defining it to be within 10 years, 15 years, 30 years, then I've had some severe scars that have completely vanished, but it took about 15 years. Okay, so the true answer, if you look up on the medical web pages and the med sites and PubMed, the answer is going to be scar tissue is not a permanent fixture. Okay, basically it has taken place. Scar needs to be remodeled so it can tolerate the stress and forces that the body encounters throughout the day. Basically, once you've adapted to that, it's got its normal range of motion and everything else. And if you can catch it in the early stages, I'm not saying like the next day, but within a few months of the scar, and you can start helping the fibers lay down properly, start leveling out the scar, making it blend in with the adjacent tissue. Then over the years, that scar will disappear. It's just going to take a while. Now, not saying if you don't go out, or if you go out in the sunlight and get a tan, keep in mind, these don't have sweat glands, they don't have hairs. You can still see remnants of the scar. I think that will always be there. Okay, especially if it's on. You've seen a lot of people when they get the buzz cuts, they have scars on their head. It's because the hair follicles don't grow in. Okay, so you'll always have a remnant. Now, what we did whenever we had a person with scars come in, my wife and her therapist, or even us when we would do ART and PNF, we had kind of a 4-step approach. Basically, we did a light stroke around the area, just a simple touch. And the simple touch, don't think the simple touch is just for mechanical means. It's also for emotional means around the scar too. Okay. We'll get into that in a little bit. But basically, we would mechanically first stroke around the area, to release fluid and toxins or relax the surrounding tissues, okay, and to reduce the pressure on the scar, okay. And also, you can help desensitize. It's like running a weed eater in your yard for 5 minutes. Your hands are numb. You can help desensitize that. Now, once we feel that is fully accomplished, the next one, we would start doing some directed myofascial unwinding strokes, slow, constant, steady pressure that moves, you would only move as the tissue releases, and you can really feel it underneath start to release. Okay, it's kind of like doing a deep stretch. If you're doing a hamstring stretch, you kind of slowly go into it, take a deep breath, relax, and then you can actually go a little bit farther. Kind of the same thing. Okay, they're applied in any directions that the adhesions can be felt. Sometimes the stroke directions may cover as many directions as lines found in like an asterisk, all different directions. This is a feel thing. This is the tactile sense that takes, I'm saying, a long time to develop, and it's kind of an intuitive thing on which way the tissues are going by having eyes in your thumbs and your hands. Now, the third step, speaking of thumbs and hands, working with the scars, my wife and I, even and some of my other docs, we found it better to work with our fingertips versus elbows. I know we got a lot of forearm and elbow and even feet people. For us, it was always more conducive to realigning some of the tissues and actually feeling when we did our fingertips. We have more nerve endings in those, okay? So you elbow people and forearm and feet people, my thoughts is if you're going to be working with a scar, use your hands around the scar when you're getting really close to the proximity. Use your elbows in the broader areas farther out, okay? Just my opinion, what we've seen over the years. Third step is we would start applying specific fiber strokes. Basically, they are going to be moving with the fibers directed. Basically, the myofascial ones have already kind of, like the asterisk, have already kind of loosened them up and got them all spread. Now we're going to try to start lining those. There's where we're going to be going parallel with the scar line, start lining them down. Okay, and then we're going to get a little bit deeper with this. Okay, so then we start going deeper. Now, the fourth step, repeat number one. Once you get them all kind of lined out, then kind of go over. It's kind of like a sandwich. You have the nice easy up front. In between, you kind of stir them up and get them all loose. Then you kind of go ahead and lay them all in line. Then you put your other half of the sandwich back on. You kind of nice and get the fluid going and kind of stroke it back out again. Okay, those are the four steps that we did, and it seemed to work over the years. We got some good results with them. Now, remember, with scar tissue, just the doctor in me is coming out. It doesn't have the same tensile strength or circulation or nerve supply as non-scarred tissue. It's also less flexible. So if you have a severe scarring and you're trying to stretch it, keep in mind that it won't have the name, normally does not have the nerve supply, so they can't tell you, ouch, and nor the same tensile strength. So if you're stretching scar tissue that crosses a joint plane, use caution on that and be in the moment with the client so you can watch every sign and use your intuition on this, okay? Because you don't want to hurt anybody on this, and you definitely don't want to reopen a scar. Now, this you would not massage. This at first I thought it was a knee when I seen this picture, but it's actually an elbow. This is from ulnar nerve release surgery. These are quite popular. Managing the scar is not fully healed can cause damage to the developing tissue, as it can delay healing. We've talked about kind of how the tissue will start healing. So if we get in there and start poking around and disrupting this, we can really screw things up. In general, the scar must be fully closed and no scabbing present to begin scar massage. I would also say there should be no rough fraying of the tissue coming up. We have to be careful of that. There shouldn't be any rubor or red around the area, and you should be able to take and poke, not dig in, but kind of poke it a little bit and work it without causing an excess of pain on the patient or client. When you can do that, then I think you can start doing some of the stuff, okay? Especially right on the scar. Now, you might be able to start working around the tissue. I have no problem with that. Just don't be spreading the skin apart. That's a no-no. Work in the direction. I have actually scrubbed in on a few ulnar release surgeries, and if you guys have ever get the chance to observe in a surgery, try to get an ulnar release. Basically, whenever your little pinky and ring finger is going numb, if they determine through a nerve conduction test that it's being caused by a adhesion, fascial adhesion right in here by the ulnar, right at the elbow, they will go and do an ulnar nerve release. Basically, they incise this. They literally take the nerve out. It's like a tubing. They'll take the nerve out, and they will actually take their fingers and they will scrape the excess tissue off of the nerve. Just imagine when you hit your funny bone, how that feels. This is the same nerve that you're taking out of the socket and you're scraping the junk off of it. Then you're putting it back in and you're stitching it up. Oof. It gives you the heebie-jeebies just thinking it. When I was watching this for the first time, I swear to God, I was having all the sensations just by watching this thing. My elbows was going nuts. And then at nighttime, trying to sleep that night, yeah. So that's some of my memories from an ulnar release. Now, the effleurage massage, basically, my wife always started off with these. The main thing on this was basically to help with drainage and to help get fluid moving, okay? Gentle circular, you guys know what these are, so I'm not going to try to educate the teachers on this. Gentle circular draining motion within the scar itself. It's a semi-firm stretch of the skin on both sides of the scar, straight line, then in the circular motion. We found the straight line parallel with the scar works good first, and then once we feel that is adequate, then we will start the motion from the outside and work our way in. Okay, again, we always start at the periphery and work inwards toward the scar, monitoring client three G's: grunt, groan, and grimace. Their body habitus, that they're twitchy. Also monitoring the muscle fasciculations as we get into. So if you have a scar, start the periphery and work inward toward the scar, no matter what type of technique you're doing, and monitor on the way in. Even if it's not a mechanical, it could be an emotional thing as you get closer to the scar that the client is manifesting. Myofascial release, this is after you've already kind of loosened it up a little bit. You work from the outside periphery and you've gone in. This will help release the constriction, okay? Stretch the skin next to the scar place. Now, you don't pull it apart. You work the direction of the scar, okay? Now, you can also, I tried to find a good image, but I couldn't find one, but you can also have this thumb behind this thumb as an anchor while this thumb stretches the tissue about 1.5 inches. Then you move the anchor down and do the same thing, and you inchworm it all the way down, okay? You can also have this thumb anchor and have this hand extend the wrist back. Instead of direct stretching, you could do indirect stretching. Have this thumb anchor there, have this hand extend the wrist back. Then you move it down a little bit and extend, down a little bit, extend, okay? Just an example. You can do that on knee, elbow, anything, basically any place that you can have a joint close by. You can do an indirect stretch versus a direct stretch, okay? Like on a quad, you could do a direct stretch by doing the anchor and stroking along the scar, or you could anchor, then flex the leg, okay? All depends on how you want to do it, okay? Now, cross friction or deep transverse friction, basically this is applied to the lesion in the transverse direction of the fiber, okay? These have been known to have very good results in mature or immature, okay? Never progress beyond a comfort level of the client. Normally about 5-10 minutes of this is enough, okay? Now, this is more of I'm going to say it's more of an aggressive approach to working with the scars. So keep that in mind. The client has to be really comfortable. The scar has to be very pliable at this point. You've had to have done a thorough job of warming up the tissue. Basically, it's for treating. You can also use this for chronic tendon inflammation. The purpose is to basically create a small inflammatory response to help further healing. It will also break up some of the bundle fibers. Now, basically, I have done a lot of this myself with patients with plantar fasciitis, okay? The plantar fascia, as you guys know, comes from the Achilles all the way down, it comes all the way up and attaches up here to the balls of the feet. Now, if you bend the feet back or the toes back, you will feel the band. You can kind of see a tight band protruding right there. Like I imagine it as guitar strings going up. And when you extend the toes back, you will feel one or two of those strings that are really tight if it's problematic. Then you can do cross friction or deep transverse to loosen any fascial adhesions that might be present on that band. Then I like to go ahead and I will take and do the indirect stretching. I'll take these fingers and hold at the base of the band while I extend the toes around. I'll do some indirect stretching. I'll stretch it out. Then I'll have the client go home and start off with tennis ball rolling for the first week, and then I'll have them progress to a golf ball rolling underneath the plantar fascia, underneath the foot as they're sitting down in the chair. And that seems to work really, really well. Now, just a little bit more on this. TFM, deep tissue, perform site image, breakdown scar, pliable, functional tissue. Basically, I'm not going to read the whole thing to you guys. This is going to be in your notes. I don't want to burden you with all that. But basically, it directly affects the manner in which tissue heals. This is really going to be breaking up some of those silly string cortexes that have been laid down and then start laying them back down in a more aligned manner with the rest of the tissue, okay? So really do some research if you have people with scars on the transverse friction technique, okay? Now, I get asked about essential oils a lot or what lubrication. Basically, any oils, your massage oils, will work, particularly the ones with vitamin E in it. Keep in mind, like we talked about earlier, if it's greater than 5.5 kilodaltons, it's not going to go down in, okay? It's just going to be on the surface. Excuse me. Had to take a sip of water. So one of the things that my wife used was she would also use lavender in her massage. Lavender was really discovered during a burning incident. A lot of you oilers know this, but basically French chemist Gustave discovered the virtues of oil with lavender. He burned his hand during a experiment in a perfumery in France. When the burn immediately happened, he immediately looked for the closest thing, liquid, to put his hand in, and he put his hand in it. It just happened to be lavender. Later amazed how quickly it healed with very little scarring. So that started a fascination with essential oils and inspired him to work on soldier and military hospitals. Lavender has been known to have great healing properties for burns. Now, we have our own brands. I know there's some of you probably ask, what do we use? What brand do we use? The problem that I've seen is there's some good brands out there, but they've gotten so carried away with the MLM, multi-level marketing of it, where everyone's making money off of everybody on these. Some of them are doing the right thing, and some of them are just in to make money and not helping the therapist or the clients. So I have a brand that we have researched and looked at, we use, that I like, and I've looked at a lot of them. So I'm going to advise, do your diligence if you want to get into essential oils. My wife used them. She used them on every client, basically, it seemed. She would come home smelling like potpourri sometimes. So do your diligence on those. Look at how the manufacturer of the oils harvests the plant, how they store the plant, if they control the fields, if they don't control the fields. Make sure they test the plant and its constituents. The constituents is the elements in the plant that have the healing properties or have the healing values. You have to have a high constituent in the plant oil in order to be effective, and it has to be 100% pure constituents. That is clinical grade oil. That's what you want. The only way to get that is through an IR spec, infrared mass spectrometer. It shoots infrared light through the oils, and it prints it out on a graph, and it measures the level of constituents in the oils. A lot of the manufacturers don't do that, or it's been skewed, okay, or it's a blended oil. Just do your research and find out what oils do those, okay? And make sure you get the good ones. Now, stretching. We did, and actually that's one of the things that my wife did when she was having her studio, is she did a ton of stretching. She would work the muscle, working around the joint, and then she would start with passive stretching, active release techniques, and PNF stretching, okay? Again, this is huge when you're working with scars that cross over a joint or are near a joint, okay? Basically, scar tissue will lengthen. You just can't think of an elastic band. You can't just stretch the elastic band and release it right back. It won't stay stretched, okay? So what you have to do is stretch it and hold it. I like to hold it for about 10 seconds and then let it back slow. That's one of the ways to pull a muscle, is if you're doing a hamstring, just say an example, a hamstring stretch like this right down here. If you're doing a hamstring stretch on a person, say that's as far as that person can go. You're really stretching him to the max. If that guy lets him go quickly, then you can get a pulled muscle. You got to let him go really slow back to normal. And I normally tell him before I release him, take a deep breath in, and as I release it back, I tell him to blow it out slow, and I let the leg back. I've never had a pulled muscle since doing that technique. Okay? Now, some of the styles that we use, PNF, myofascial, and ART. What is PNF stretching? Proprioceptive neuromuscular facilitation, a big $5 word, right? Basically, it's an advanced form, both stretching and contraction, okay? form of rehab, very effective. Here's a good stretching vid. But basically, if you're doing, I just want to see what my next slide is. Yeah, here it is. That's what PNF. We did a lot of PNF stretching. I did a lot of these on my disc pathology and my rehab patients, let alone the massage patients that my wife was dealing with. Good one to watch. There's a YouTube link. This will be in your notes, so you don't have to worry about writing it down. The stretching, there's really two styles that we use. It's a contract and relax. Basically, you just say a hamstring, okay? You're bringing the leg up. They'll contract it and they'll relax it, and then you'll bring it back down. That is one style. You can apply this to any joint. Excuse me, swallowed wrong. Now, the other one is hold and relax. So you can basically, whenever you bring it up to close of max stretch, like in a hamstring, basically they will contract it, okay? Then after they contract it, they'll relax a little bit, then you can push it a little bit more. Then they'll contract it, then you can push it a little bit more, okay? That's the two differences between contract, relax, and hold, relax. Myofascial versus traditional stretching. I guess the best way would be the traditional stretching would be you're stretching the muscle, not so much the tendons, the collagen, and the fascia. Okay, you're kind of stretching out like you're about to go for a run, and you see the people with the hamstrings are stretching their hamstrings. They're doing traditional stretching. The myofascial stretching, if you're really going to do some fascial stretching, you got to get into, it's called, let me think of the word, it's called hysteresis, or plastic deformation are the two that are words that are used in deforming and retraining the fascia and the adhesions in the deep connective tissues. In order to really do those effectively, you have to hold it between 90 and 120 seconds. I mean, you're really holding this thing in a long position. There's a form of yoga, I believe it's called yin, Y-W-N yoga, yin yoga, that holds yoga positions for a long time, about 3 minutes. And I've taken some classes with yin yoga. And if you're doing like the splits and you're holding that position for 2-3 minutes, you can really feel at first the muscles start to relax. Then you start to really feel the deep tissues start to relax. It's like whenever we were dealing with scoliosis patients in our clinic, we couldn't stretch or put a block, mirror image adjusting. We couldn't do the blocking for 10 to 20 seconds. We had to have that on a force over time. That's how we change things. That's how plasticity will occur. You can change the posture and change the curves with force over time. That's like your cervical wedges and stuff like that. You have to lay on them for a while. Same principle with some of the stretching if you're going to get at the deep tissues. Here is also some good ART vids. Knee, hamstring, and piriformis. Now, I often get asked, how does it form in a muscle? Well, a couple ways. Basically, you'll have your direct muscle tear, like a sporting injury or a whiplash, getting hit from behind. You'll have actually a tear in the muscle. Then the same process we talked about happens in the muscle. The clot and the fibroblast and everything else will start doing right here in the muscle. So that's why after a whiplash, if there is like, I'm going to say the SCM, the sternocleidomastoid, the SCM muscle, if there's a tear in that one of the muscles, if the client doesn't get treatment, massage, physical therapy, chiropractic, some type of a rehab to re-stretch that muscle, that one muscle will actually become shortened because it will lose range of motion, and then it will become weaker, and then it will become shortened. So what does that mean? They won't be able to turn their head as far the other way. They'll lose overall range of motion. Okay, so we got to work stretching on those. The micro tears, this is what you are going to see most of these. These are what I call repetitive stress syndromes. You're going to see a lot of these. Think of the guy that works at the assembly plant that's bending over and straightening up, lifting a widget 100, 200 times a day. His lower back muscles are going to be having repetitive stress syndromes over and over and over. Severe runners or bodybuilders, whenever you go in and you have power lifters that will explode in the gym, they're actually creating micro tears. That's how the muscles get bigger. They hypertrophy. You're going to have those. So my wife started getting a small following of power lifters and bodybuilders coming to her practice. And first of all, she couldn't do it all the time because it was really hard on the thumbs. And to actually release, I remember one of them, she had to go get a pillow so he could scream into, because you have to release the pec from the anterior delt. It was one solid sheath of scar tissue and fascia, and she had to go in and break all that up. After doing, and you can watch some of the YouTubes, massage on bodybuilders. It's very painful for some of these guys, and they sweat. The sheets were just wringing wet. Afterwards, they're sore. She would tell them take glutamine, mix some glutamine in their water. You can get it at GNC or Vitamin World, any health food store. And also flaxseed oil. You can put flaxseed oil, a couple tablespoons of flaxseed oil in a shake, along with the flaxseed you can get, grind it in a coffee grinder and put that in a smoothie. So the combination of the glucosamine and the flaxseed would really help with the inflammatory response. But she had a huge following just with these guys, and yeah, she charged double the price for them, but she was in there a minimum of 90 minutes. I remember one guy, she worked a whole hour and a half just on his arms, on his upper arms, bicep and triceps, because they were so bad. So, and she would have to do it on body parts, and she would only do one body part a week on the individual persons. Keep in mind, scar tissue doesn't just do fascia. It can also bind muscles. It can also do the myofibrils. Basically, inflexible scar tissue limits the movement that were once elastic. So if you have a person that has had surgery or a trauma and they have scar tissue formation, whether it be visible or on the inside, a lot of times that can actually inhibit the muscle from moving as well. So you really got to do some stretching if you're going to be dealing with people with scar tissues and post traumas. One of the things that we always did every time was we always heated them first. She had them go in, and she would we had the hydroculators, because studies show that moist heat goes deeper than dry heat or other conventional heat. So she always had her own hydroculator, and she'd always layer them with the pads, and she would have them lay on them for about 10 minutes. And then she would go on in, it'd already be warm, and she'd start to work on them. Okay, so she always liked heating them, and I always liked heating them. Before I did a piriformis stretch or any type of major stretch or rehab, we always heated them. I always got that question, well, after the injury, am I going to ice them or am I going to heat them? Well, it depends on what you're going to do. I have found over the years, if you're just going to go ahead and see them real quick and send them home, then we iced them. But if we're going to stretch them, then we went ahead and we heated them up prior to stretching them. Gua sha. Basically, gua means to scrape or rub. Sha basically is the petechiae or ruber that comes on up on the skin. You're not scraping like pulling the skin off, okay? Not at first. It can get that intense, but it starts off light and goes deeper and deeper. Basically, you start off light and you try to monitor what you see as well as the patient's pain threshold. Eventually, this will get down. Now, it's not like 3 or 4 swipes. This is probably 100 to 200 swipes you're doing. It will eventually get down to the scar tissue. But it's imperative once you go through this to start working like this one here. We would, after working this, once we got to this level, then we wouldn't just leave it at that. We would actually go ahead and do some stretching at this point. We would anchor, do a head flex, would rotate, or do a shoulder stretch. we would start stretching that tissue that we just broke apart, and then we would do the effleurage massage afterwards, okay? Now, when you're working with scars, keep in mind we're spirits in a human body, so we have emotions. So keep in mind with this. An example, a good case scenario would be a hypothetical example is a young female is working behind the counter at a cash register. A robber comes in, points a gun at her head, and at the same time, and the robber is blonde-haired, blue-eyed, and at the same time, she hears a fire engine go by with a siren. You got the scenario? The robber hits her on the side of her head with the gun, knocks her out, takes the money and goes. Years later, she sees a guy that looks kind of like the robber, tall, the body type, blonde hair, blue eyes, and she will get a pain on the side of her head. Or every time she hears a fire engine go by, she gets a pain on the side of her head. That's called an engram. A scar can be a traumatic event. If the scar is a traumatic event, when you start going into the scar, start working on that, you could resurface those thoughts and those emotions that were buried within that scar. So the client may burst out laughing, they may burst out crying, they may just start talking nervously. That's okay. Let them do what they need to do. I've done a lot of Reiki on clients in private sessions where we've had regressions of the feelings, and sometimes they need to get out for healing to occur. Now, I know legally we're not qualified to handle all that, but guys, we're humans and we're healers, so we listen and we can lend the ear, okay? Don't go giving advice. Well, that ex-husband, I would go shoot him. No, don't go giving advice. Don't do that. But keep in mind, you can bring up old emotions and old feelings, okay? And how the clients manifest them could be all different from client to client. They could be laughing or just start getting chatty all of a sudden. Just kind of look past that. Now, moving on, let's talk about some of the fascia. Fascia is everywhere. You like the from Netter's illustrations you pull across. That's what that is. When you open up a wound, you're going to see a white tissue layer. If any of you guys have ever done wound care, thoracolumbar fascia, the cervical dorsal, it's all over the place. Is our fascia. If you have a good piece of steak, it's that white, tough lining that's around it. That's our fascia, okay? In cadavers, you can see it all over the place, and it's very spider webby like is what it is. It really is. When I was in medical school, we had to dissect our cadavers. We had to take the skin off, and we've seen how underneath this is this looks very clean compared to what it really does. This has been worked pretty good, but you can see the skin over the glutes, the buttock here. You can see the skin. Underneath the skin, that is exactly what we look like. Especially if you've had biology and you worked on a cat or a pig. That is the fascia. Now, that is all over our body. Is there certain patterns, characteristics? You bet. Can it cause problems? Yeah, it definitely can. Now, one of the things that was interesting is I found a research study that basically the fascia in the posterior thigh or the hamstrings is very different than the rest of the fascia that's around the body. Normally, and I've seen this in our cadavers whenever we did our dissections, normally the fascia is like a smooth white layer, just like I said, like you see on chicken or on a steak, it's a smooth layer. But in the back of our hamstrings, it's all kind of stringy and kind of all little string with little balls on it. Okay. Now, why is that? I got to be honest. I don't know. I could come up with some guesses. It's for locomotion, probably. It needs more anchoring in the back for propulsion and stopping short. That's the only thing that I can come up with. What does that mean? it can mean that we can get a lot more adhesions back here. It can mean that stretching and trying to release a hamstring is going to be a lot more cumbersome than doing a quad. It can mean a lot more prep work, preparing the area first before you start stretching. Okay, so keep that in mind, and that's the only area that it's really found. Now, here's a good thing also. Fascial strains are basically, they can be identified on their own. Okay, how can I put this? Whenever some of the fascia will actually go up in the back of the hamstrings, will actually go up in between the fat layers, like folds. Could that be why there's extra dimpling, why cellulitis shows up really predominant in the glute folds and the hamstrings and the thighs? I don't know. It's a good hypothesis. Okay. So the other thing here that can be distinguished clinically from muscles by the absence of local tenderness and maintenance of muscle strength. This is an important clinical distinction, as a muscle tear will require time out of activity, whereas a fascial strain can be managed with minimal absence from exercise. So in other words, what it's saying is, if a client comes in and they don't know if they have a muscle strain or if it's a fascial strain, well, if it's a muscle like a hamstring strain, and you remember it's strain versus sprain. A sprain, SP, is with the ligaments. A strain, ST, is with the muscle, okay? So if we have a hamstring strain or a minor tear, they're going to be out for a while. But if it's a fascial strain, then they could probably resume normal range of motion work, and then after some sessions, then go back into full-blown activity, okay? I know you're asking, how do we tell, how do we diagnose and all that. I don't want to get into showing you guys diagnosing, but basically, if it's a hamstring one, the client's laying on their stomach and they're flexing the leg. If you passively flex the leg again and it's hurting when you flex and extend the leg out, it's probably more of a muscle, okay? The other thing too is, if you anchor up under the gluteal fold, if you flex the ham, bring the leg up, you're flexing the hamstring, you're getting a ball right here, and you anchor upward in the gluteal fold, and then slowly, while you're anchored, extend your leg back out, then you're stretching that fascia as well. And then that, you should actually feel the fascial rolls under your hand as you go down. You can actually feel some of those. So that's kind of a little, I'm going to say, for lack of a better word, diagnosis. And I know we don't diagnose, but just kind of give you an idea what you're dealing with. Now, fascia is like a big bodysuit, okay? Basically, what they found out here is that surrounds the muscle lower limb is continuous with the thoracolumbar, okay? And it will also go down to the Achilles. Basically, we have our fascial patterns all the way down. So, and it crisscrosses in the front. So when you're stretching, some of the rotation things is good to stretch the clients in a rotational manner. Flexion and rotation can actually help with these. Can a problem down here manifest with an opposite side trigger point? You bet. It's because it's all connected. What happens if a client comes in, they have a reoccurring trigger point up here, and you're doing everything with the upper body, the torso, the shoulder girdle, the subscapular region, and it's still not helping. Look at their opposite foot. See if they have flat feet. Here's a good thing right here. If I have a flat foot, like this is showing, with that pattern here, I'm going to have a typical pattern. It's going to have a drop shoulder on the opposite side. So if you have a client that's coming in with a reoccurring shoulder trigger point or tight spot, say, you know what, Bob, here, let's just do this. Stand up against my wall, face the wall. I want to look at your posture. Now, pretend I'm not looking at your posture. Kind of shake your head and stand normal. If you see that shoulder is dropped, have him take his shoe off. See if he has a fallen arch on the inside. You correct the arch with an orthotic or an arch support. Get him a good shoe. Then you work that. You'll start actually getting rid of that trigger point up here. Okay. Now the other thing too, I don't want to go in too much in this, but because that's from another webinar. But if you have a fallen arch, what's going to happen? You're going to have a pain on the inside of the knee because you're going to have internal rotation of that leg. It's going to cause a wedge, an open wedge on the inside. Also, this side of the pelvis, the ASIS, will drop anteriorly. It will drop and it will go forward on the side of the fallen foot. So imagine that torsion by the time it gets up here. It's really cranking up in torsion. So you may have to work that kinetic chain all the way up. Okay? So if this shoulder is dropped, a lot of the therapists I've seen, they'll mistakenly think that this trap is in spasm and tight all the time. And they'll just dig and dig and dig and dig and dig and stretch on this trap. When all in all, it's more of a structural problem that can be addressed down here. Okay? So keep that in mind. I didn't put them on this webinar, but you can also, some of my other webinars, I have an image. You can put a grid board in the back of your door. It's just a paper grid line. Have the client stand there. It really helps you. Posture Co is an online app. You can download it to your iPhone or iPad, and you can actually take a picture of the person, then you can click little spots, then hit calculate, and it'll calculate for you these. The other thing too is anterior head carriage, forward head posture, normal. It's been shown, we have our gravity line. We're supposed to be ear over shoulder. For every centimeter that we're forward of that gravity line is equal to 10 pounds of pressure on the back of our neck and our spine. Okay, so we can really cause havoc with the fascia because we're really straining the fascia. A pulled muscle, a stretched fascia over time is going to start contracting or start pulling back or tightening up, or the fibroblasts are going to start putting more stuff to help support it. Okay, they'll start putting more fascia down. That's where you get adhesions formed. Again, kind of what I talked about. I'll just hit it real quick. Flat foot drops, internal rotation, knee goes in, wedge. The pelvic on the side of the flat foot will tilt forward. Here's your fascia that you want to look at, okay? Trigger points, going to be all in these areas. That's where you're going to find your trigger points. Well, I didn't realize that was the next slide, but speaking of fascia, you cannot talk about scar tissue, fascia, adhesions without mentioning trigger points because they're going to be all over the place. You're not going to do any release of fascia unless you address the trigger points. So I had to put some trigger point slides in here. So I know this isn't a trigger point webinar, but after talking to my wife, she figured it was very applicable to put these in here. So I got some slides on what trigger points are, and we're going to finish it out with trigger points. One trigger point is called the pain in the, but a collection of many trigger points is actually called myofascial pain syndrome, or MPS. Myo meaning muscle, fascial connective tissue. See how this ties in what we're talking about? Pain syndrome, ouch, or pain, ouch, and syndrome, I mean, it's kind of mysterious, We're starting to figure it out a little bit. We're starting to get a handle on this. We're seeing it's related to posture and daily activities. Central TPs, a central trigger point, is isolated in the skeletal muscle belly. Okay, it's in the belly itself. Okay, the attachment is located at the junction of the belly or a tendon. Okay, usually attributed to the tension that feels like a tight band. Okay, now satellite, it's activated by the key trigger point. So if you hit on the central trigger point, then sometimes the satellites will start showing up. Okay, so keep in mind on those. The key trigger point is what has a pain referral pattern along a nerve pathway that activates a latent trigger point or creates it. So if you have like this here might be a central trigger point. This here would be your attachment trigger points up in here. You start working on these, and these little satellite dudes might start showing up. Okay, it's because you're releasing along the spinal accessory nerve, the subscapular nerve, start along the nerve pathway and the dermatome pathways. Okay, they'll start showing up. So what do? If you already have these present, start working those, then work to the main big boy. That's how we always did them. Sometimes, once you get these cleared out, Then you get on the big guy. If you start working him, they may show up, but they're only going to be about a quarter of their normal potency. Then you can address those pretty easy, okay? Here's one, the levator muscle or the mouse muscle. Basically what I found is people that do a lot of computer work, if they don't have their elbow on a table, or if their elbow is just kind of hanging in the air, after about 15-20 minutes, the levator will start subconsciously, it'll start contracting. And you'll start getting a big knot. The referred pattern, primaries, the pattern could be along the scapular border all the way around to the deltoid. There is a good stretch. After you've already worked the trigger points, you always stretch the muscle. And then if they show up, you rework them again, okay? I normally try to stretch and rotate the head away from the side being stretched. Good at-home stretch. The SCM trigger points, the satellite ones, can show up in the forehead, the frontal lobe here, right behind the auricular or even in the ear, okay? You can also have some show up around this, a spread pattern, even though it's right here. So if you have a tight SCM, like a whiplash you're working with, see how she's stretching? This guy here could actually say as she's stretching, he's feeling tension up here. Then you could always do a 2-point release. Have one hand on the primary muscle belly one and one on the satellite one as you stretch, okay? So keep in mind that that's the pattern for the SCM. The QL, we know our quadratus lumborum. Actually, just imagine this, guys. Imagine the client comes in with the flat foot on one side. We all know, we just covered that. The flat foot will cause internal rotation, and it will cause the side of the pelvic to tilt forward. So imagine this side is that involved side, and that side is tipped forward. What's that going to do to the QL? It's going to stretch it. What does a stretched muscle do over time? It'll start contracting, okay? So they could have pain. So here is some of the pain patterns that, or trigger point patterns that can be manifested from that, from the QL, okay? So keep that in mind. So if you have a client that keeps having these trigger points showing up, check their feet to see if they have that on that side, a fallen arch. It's huge how it's all related. Some good QL stretches, just like this. Inhale, exhale. On the exhales when you go in deep, okay? And again, watch for patient comfort. They have to relax. It's not about you, how can I put it? It's not about you digging in the depth. It's about how relaxed the patient can be while you dig in, okay? Then we stretch them after we release them. Psoas, same thing, okay? That normally shows up in the front. It can also show up really deep. There's not a lot. There's a couple good psoas stretches that's very non-invasive, and I thought I put the link, but I didn't. You can catch them on YouTube. Put gentle psoas stretch or psoas release, and there's a few of them on there that will come up. Multifidi, okay? Here's the patterns that the multifidi will be. How do you stretch the multifidi? You go with the fibers, okay? A lot of times you'll anchor it. You can go, I like to go toward the sacrum, but you can anchor up top while one hand's going toward the sacrum. You can also do the cat-camel pose, okay? That's really good, and hold it. This person here, as they're going up, they're exhaling. You don't inhale on the way up. You exhale on the way up. Why? Is because the diaphragm is connected to the lower lumbars. When you exhale, you actually can get more stretch out of this, okay? All through here, the longissimus, and these are going to be in your notes. This is mainly just for like a little reference thing. You guys can print these out. I'll send these to you in the notes, one slide per page. That way you can print them out if you want. Again, how to stretch. Same thing with this. Whenever you're stretching at home, this woman here I would have go so far where it's uncomfortable. Take a deep breath in, and as she exhales, she could probably get about another 2-3 inches of rotation just because of the diaphragm, okay? The glute, any type of glute. Men, if you have trigger points on the lateral part of the upper calf to the middle hamstring to the fold, or right at the tip, you probably got a glute min entrapment or a glute min problem. So you'll start working all those. They can even go down to the side of the TFL. The medius is going to be up more high, okay? Sacral base, all this. Now, where I do Reiki on clients, a lot of ones, when they get emotional ties, when they're, the base chakra, if that is not open, I'll start seeing trigger points. They'll be complaining of trigger point manifestations over here too. So a lot of times I would do energy work on them along with trigger point release. It's a great tie-in. The maximus, the L butticus muscle. Normally, that's going to be right in on the internal fold and right underneath of the fold. That's where your trigger point's going to be on this thing. So if you got that, then you can do your general stretches. You can do the roll to kind of roll it out. This is a great stretch to kind of do that, to stretch the piriformis and the glutes. Now for the upper arms, the supinator brachioradialis, this is all going to be right where the trigger points are. So you're going to see a lot of these type trigger points in people that are mechanics, people that lift heavy weights all the time for the gripping. That's where a lot of these are going to be. The best one that we've seen is just like this. Either they put it on a bench and they're leaning over on it, or you do that for the supinator and brachioradialis. The extensors, you're going to have your trigger points right here and here. That's where they're going to show right up. Okay. These here we've seen in a lot of electricians or people that use like tools like screwdrivers, turning things right here. We've seen a lot of these in those. I've seen also a lot of these lately in the last few years. People with typing keyboards, seen a lot of this stuff that needs to be released. Again, just the opposite of the muscle. Triceps, they're pretty well local. You may have one around the olecranon right around here by the elbow, but it's mainly going to be up here, and you can do a simple elbow stretch on these guys to get those out. Supraspinatus, going to be right on top, and it can manifest a little. I'm going to say that's maybe 20% of the time. Most of the time it's going to be right in here. You're going to get your trigger points. A lot of people don't know how to stretch the supinatus. This is how you stretch it. You can have them lay on their back on your table and take their hand, anchor the elbow, and stretch the hand down, or they can do it at home. Just get a broomstick or a dowel and rotate it around backwards. That's a good supinatus stretch, or a supraspinatus stretch. The infraspinatus, that's going to be more out in the deltoid. That's going to be minimal out that way. You're going to have more out here with the primaries. The satellite's going to show up there. Best way to stretch that on the client is to bring it across. Okay, you can put your palm right here and stretch that across as you hold your palm as an anchor. You'll get a good stretch on that. Piriformis entrapment. I get a lot of these coming in. People think they got sciatica, and they think they got a blown disc, when all in all, it's the disc is fine, and they have a piriformis entrapment. They have fascial adhesions, or the piriformis is just in spasm. Again, imagine the flat foot. You're going to drop that pelvic forward. What are you going to do? Whenever you have an internal rotation, you're going to stretch that piriformis. Stretched muscle's going to contract. Over time, the contracted muscle's going to form scar tissue and adhesions. It can entrap the sciatic nerve, and you can manifest pain. Rectus femoris, always check the end there, not directly in the muscle belly, but the origin, and it can manifest any pattern down here. Again, you hold where the primary insertion is, and you bring it on around. Okay. The adductor muscles, same thing. This is where your trigger points are going to show up. Easy. This is called actually a Patrick Fabre test, but you can do a good adductor stretch. Put your palm on the ASIS and then stretch down. Make sure the foot is above the kneecap, not on the kneecap, because you can cause pain, and then just stretch down. You can actually have them push against you and then relax, and you can stretch it even more. Push against, stretch it even more, okay? I always get asked on fibromyalgia. I'm not going to go in too much on the fibromyalgia. If you think, how do you know if it's fascia pain or trigger points versus fibromyalgia? I always get asked that. Well, there's organization that deals with this, and they've come up with 11 points that the patient must have present before it's diagnosed as fibromyalgia. And it is physician dependent, but the ones that we got, and I apologize, I think you guys can see these, but before I send this to you in notes, I'm going to recolor these into I'll probably color them in a red, where like low cervicals in white. I'll cover these in red. I'll make these a little bit clearer. I put that up late last night in here. Basically, this here's your controls. The greens are your control. Your left thumb, when you pinch on that, it's going to be tender. The forearm's going to be, that's how you kind of, and you pinch to get kind of an idea of the patient's pain tolerance. So these are your three control areas. You push down on their forehead, you push on the forearm and on the thumb. That kind of gets you an idea. Then you start poking around to these areas, and if they are more hypersensitive in 11 of those compared to these, then it would be prudent to send a referral for proper diagnosis of fibromyalgia. Now, you should only push about 4 kilograms to kind of get a feedback on this. Now, I know you're wondering what 4 kilograms is. How much is 4 kilograms? Just enough to blanch a thumb. That's about 4 kilograms. 4 to 5 kilograms is enough pressure to open a pop top on a can of Coke, or some of you guys on a can of beer. That's about 4 to 5 kilograms is about that pressure. Okay, so that's what you want to put. So where are we? Where are we now? I think we are 11:28. I think I got you guys pretty close on time. Yes. So housekeeping, questions. I'm going to be here for the next hour and a half converting. I'm going to redo that one slide for you guys, make it better. So I'll be here. If you guys got questions, shoot me an email, info@drbrianhawley.com. Again, give me a few hours to get this converted over to a PDF and get it converted where I can upload it. And I'll send all the stuff out to you guys. Probably later on this afternoon, I'll get everything to you guys early evening. And along with a mini test. Take it, watch it whenever you want. Get it back to me. And when you do the test, you don't have to mail my form back per se. If you do, fine, highlight it and send it back. If not, just send the answers. My assistants will grade it. They'll look at it and make sure you put in there how you want your name to appear. Okay? So with any credentials, especially you alphabet ones. So put those on there. So I hope you guys, it was an hour and a half. It was a long webinar. I hope you guys enjoyed it. Anyways, I wanted to say thank you guys. And today's Tuesday. Have a great rest of the week. And I'll be yelling at you guys soon. Take care.